I'll just start off today by acknowledging that we're on Kaurna land today, or I'm on Kaurna land, at least working and living on Kaurna land. Pay my respects to elders past, present and emerging, and acknowledge that this always was and always will be Aboriginal land. It's land that was never ceded. I extend that respect to the lands of the traditional owners of the lands of wherever you might be today, if that's not Kaurna land, and to any Aboriginal and Torres Strait Islander people who might be joining us today. This morning, I apologise for our little delay. We did kind of sign on early and we thought we'd get it all sorted, but the technology was not playing ball with us this morning. But I'm sure you can all appreciate that. It's happened to all of us. But I'm very excited today to welcome Mehak and Noha from STARS, supporting survivors of torture and trauma in our community. I first met people from STARS a few years ago. So a couple of the workers attend our comorbidity network from time to time. And I met Mehak at the Hoi Sin committee, which is a committee run by CASA every few weeks in terms of addressing mostly alcohol and other drug issues. And she spoke about particularly about their Thrive and Connect program, and I thought it would be a really interesting topic for one of our seminars to talk about that program, and also more broadly about the services of STARS. So I'll hand over to the ladies, and they'll run through their presentation, and then we'll have time for questions at the end. But please, if you have questions along the way, feel free to pop them in the Q&A function so that we don't miss them, and we'll address them at the end. So I'll hand over to you.
Thank you so much, and welcome everyone. Thank you so much for the opportunity to present. I hope you can see the slideshow properly. It only means that I can't see any of you. I can only see my slides. And so, you know, if you have any questions during the presentation, feel free to just jump in, but maybe Noha can help with the questions if anyone has any burning questions throughout, but we do have time for questions at the end. Yeah, so we're going to start. I'm going to be going through the slides first, and we're both going, Noha and I are both going to take turns to do this presentation today. So thank you for the acknowledgement of the country, Sam. I'd like to do that again. Before we begin, we'd like to acknowledge that the land we meet on today is the traditional lands of the Kaurna people, and that we respect their spiritual relationship to the country. We also acknowledge the Kaurna people as the custodians of the land, and that their cultural beliefs and their heritage beliefs are as important to the living Kaurna people today. This is the agenda for today. So I will be talking a little bit about STARS. Mind you, STARS has grown as an organization over the last couple of years. So I will try and keep it brief because we can share quite a lot of information about the services that STARS offers. But today is going to be focused more on the Thrive and Connect program. So broadly, I'll share what STARS does and what we do. Sorry, what STARS is and what we do. I will try and give you all an overview of these terms of refugees, migrants, and asylum seekers and how they're different. I will give you a snapshot of the different programs at STARS, but we will talk a little more in detail about the Thrive and Connect program that Noha and I are part of, and the referral pathways, not just into the Thrive and Connect program, but also broadly into STARS. Noha will then talk more in detail about a case study. She will include some therapeutic approaches that helped her work with one particular client. And towards the end, we will try and discuss highlights of the case study and some particular key elements that helped bring the case study together or are important considerations when we talk about the case. And we will have time for questions at the end. So STARS stands for the Survivors of Torture and Trauma Assistance and Rehabilitation Service. We are a specialist not-for-profit organization that was established in 1991, and we support people from refugee and refugee-like backgrounds within South Australia but we are part of a larger FAST network of services. So essentially, we have a similar service in every state in Australia and across the globe. We provide culturally relevant therapy and support to individuals and families, as well as communities, to support their torture and trauma recovery and rebuild their lives in Australia. So we also, within this, provide psychosocial counseling and support. For example, we can also offer support to consult with GPs and psychiatrists, allied health professionals such as mental health clinicians, social workers, and psychologists. We offer group work, and we used to have a natural therapies program for pain management, but we now have a separate program that manages that provides support to clients who have pain related to their traumas. And we have a range of community development activities across the programs that we have at STARS. So a little bit about the refugee experience, and I think this is fundamental to understand what we do as STARS and the Thrive and Connect program. So more broadly, a refugee is defined by the United Nations Convention as any person who has a well-founded fear of being persecuted because of their race, their religion, their nationality, due to being part of a social group or having a particular political opinion. So for a refugee to be called a refugee or to be given that status, a person must be outside their country of origin, and unfortunately, they have to be in a situation where they are forced to flee and to go into another country, which is a country where they are able to register themselves as a refugee. And this person cannot legitimately return to their country of origin for reasons of personal safety due to being in one of those categories that are on the slide. An asylum seeker is slightly different. They are outside of their country of origin, and they have made an application to be recognized as a refugee. So they have an extra step. They are not given a refugee status yet, but they were forced to flee their country of origin. They have now arrived at another country of origin, and they have made an application to be given the refugee status, and they are waiting for their claim to be processed. And more broadly, these are some of the differences between migrants, refugees, and asylum seekers. When we talk about migrants, the main thing here is choice, because as migrants, we choose to make a new country our new home. We have the choice to take belongings with us, to say goodbye to our friends and family, and have a bit more certainty in our life as to where we are going. Choice with what kind of visa we have applied to, and can return to our country of origin if we wish. However, if we are a refugee, we tend to leave our country in under traumatic circumstances with little or no possessions, and our life is a little more uncertain. We leave behind friends and family who are in danger or difficulties of their own, and we may not be able to return to our home country. And we don't really know where we will end up when we are resettled. So again, it could be a refugee camp or a detention center or a host country, but it is usually uncertain where we will end up. This map or diagram shows the three broad stages. Sorry, it should go back. Yeah. This map shows three broad stages of the refugee experience. So there are the pre-migration trauma experiences that happen in the country of origin where refugees and asylum seekers come from. Then there is a displacement stage where they flee their country of origin and try and find displacement is where it's like a short-term settlement process. And then there is a final resettlement process. So if we were to think of Australia, Australia is the final resettlement country for a lot of the refugees and asylum seekers who have made it here. But refugees often experience multiple traumatic events over a prolonged period of time. Noha is going to talk about the resettlement challenges. I'm keeping an eye on the time. And I think Noha can talk a little more about the resettlement, and she's going to try and weave some of these concepts in her case study. But essentially, when we talk about resettlement for people from refugee or refugee-like backgrounds, we're talking about settling into a new culture, a new system, having to learn a new language, trying to navigate the housing system, or finding employment and making new friends. This can cause a lot of overwhelm and anxiety for people who are in that resettlement process. The change of slide is taking time. Okay, so here are the STARS programs. We have an adult counseling program. We have programs for child and which is called the Child and Youth Program. We have a refugee mental health clinic where we provide psychologists, mental health social workers, and psychiatrists, as well as some casework, practical support, and advocacy. We have the ARANAP program, which is a refugee health nurses program. We have the Thrive and Connect that we will talk about in a bit more detail. We have community development programs, and we also offer training and education. So more broadly, the Thrive and Connect program is something that I'll talk about in a bit more detail today. Noha and I are part of the Thrive and Connect program. This program is for adults who are 18 years and above, so it is an adults only program. And it's for people who are experiencing distress or mental health challenges and belong to the CALLED community, or what we call the culturally and linguistically diverse communities. So the Thrive and Connect program is a PHN funded program. We receive our funding from the Primary Health Network. And we are able to see people not only from refugee backgrounds, but also refugee-like backgrounds. So for example, it could be a migrant person from a migrant background who has settled here, but has found themselves in a more vulnerable situation due to factors such as trauma or having a language barrier due to not being able to speak English, etc. Within the Thrive and Connect program, we provide two types of support. We have bicultural workers who provide low intensity support, and we have clinicians who provide more clinical care coordination or complex care support. Within the bicultural workers, within the low intensity support, the bicultural workers are workers who have lived experience, and we value people who have lived experience of being in similar circumstances or experiences. And we see that as an asset because we feel that people with lived experience have the skills to support people who have similar challenges. So a bicultural worker will help clients understand what is happening and why. They provide information on services. They help clients to link into relevant services such as the health services or legal services, housing support. So they do offer practical support. And they help in offering some social groups that help with social skills and reconnection within the community. And our main aim is to try and provide support to clients with an ultimate goal of reducing the impact stressors have on their mental health. We also offer clinical care coordination, and within that, the clinicians, which is for our program, it's Noha and I who are the clinicians. We provide more complex care coordination. We provide strategies to help clients, process their stress. Noha is going to talk more about that in her presentation as well with the case study. We help in developing a recovery care plan. We help coordinate referrals to allied health professionals or any other services that will help in the recovery of the client. And we provide a coordinated approach to clinical support. I'll talk more about the referral process later. I think it's time to hand over to Noha. Noha, are you okay with that? We can talk about referrals later at the end of the
Yes.
presentation.
Yes.
Because it is a simple process,
Of
but
course.
I think it's worth handing over to you. And just tell me when you want the next slide to come up, because as I said, I can't see anyone. But I'll take
Yes,
it
sure.
to the case study.
I'll let you know. All right.
And I'm handing over to you now.
Yes, thank you so much, Mehak. And again, I repeat my apology for the unfortunate technology thingy. But as I always say, we're all going to be victims of technology in a way or another. So I have the privilege and the honor to be part of STARS and to be a mental health counselor in the Thrive and Connect team. And I think I'm even more privileged to have worked with that specific case. And I hope that it's going to inspire you in the same way that it was able to do to all of us in the team. So let's not just call it a case study. Let's just call it a story of a brave woman who really inspired us all. Can we go to the next slide, please, Meg? So first of all, before talking about that lady, let's give you a little bit of context about the background and the history. I'll do that very briefly before going into the details and how did she get to know us and to receive our services. So this woman comes from a conservative background, which we can call a little bit of a patriarchal society. She has faced for so many years somehow let's call it, I'm not going to say a gender discrimination, but because of being within that cultural context, she was always expected to do certain roles. And this is a very important part of the story. She has been going through years of abuse, starting from her family, passing on to when she got married. And she lived with her in-laws for so many years, who also abused her. Then she came and she moved to Australia with her husband, who continued the abuse. The type of abuse that this woman has faced throughout the years were physical abuse, emotional abuse, and financial abuse as well. When she came to Australia, it wasn't easy for her. As we were talking, that the migration stress is a very significant element. And there are so many stressors that were linked to that specific woman. First thing was related to the lack of language, not being able to get a job, not being able to communicate, not having any sort of social network or support, especially with the problems that she has been having with her husband, who started to treat her really bad as soon as she came to Australia. And he continued the abuse, leading to a sense of abandonment when he decided to completely desert her and left her in what we call a state of limbo, emotionally and legally, because he did not divorce her and yet he's not living with her. So she had only one person who is a very distant relative who was able to take her in. So as you see, the context before we talk further about the case. Can we go to the next slide, please, Meg? This woman came to us after being referred by her GP, because our services, as we said, we provide our services to the cult community. So her GP made the referral. She came with suicidal ideations, symptoms of insomnia, continuous hopelessness, flashbacks, fatigue, emotional dysregulation, distorted self-image, low self-esteem. As you see, that's a very heavy package for a woman who is only 30 years old. And it was a very new environment for her. And based on all these symptoms, we believe that it is aligned or it goes in line with 3 disorders, which is PTSD, major depression, and generalized anxiety disorder. Can we go to the next slide, please, Mehak? Now, let's go to the story. And how did it all begin? And where did we get involved, and how we were lucky to be part of her story? It's just a little more click. Thank you. So let's start by saying what happened and the biggest points. The first thing in our therapeutic plan and intervention, as you see, was safety and stabilization. And this was because when this woman came in, she first of all did not know what is therapy. Who was I? What do we do? What does it mean to be in a counseling room? And what is expected? She did not know the difference between a GP, a psychiatrist, a psychologist, a counselor, a social worker. So it was a very new territory. But the only thing that she knew was that she felt safe enough to talk. And she had very active suicidal ideations and suicidal attempts and suicidal plans. So when she was on the verge of doing it, she decided to come to STARS. And she was in one of the sessions where she had a total nervous breakdown. She sort of de-associated within the sessions, hysterical tears. And the only thing she could say, if you do not help me, I'm just going to go kill myself right now. I think we could take pride in this point, Mehak, because the whole organization stood there. Everyone was around that woman, giving her support. Whoever was working left whatever they had in their hands, and we all collaborated to make sure that she gets safe. Needless to tell you, some administrative and boring procedures that we did, but the end result is that we were able to get the ambulance very quickly and to make sure that she entered the ambulance and was taken to a local hospital. Unfortunately, she did not have a very pleasant experience at the hospital. Actually, it triggered her more. And that was very, very unfortunate. But at the same time, she came the next day because she needed to feel safe, and STARS was the only place that provided her with that. So this is where it all started. Okay, what are we gonna do? Let's be solution focused, especially the Thrive and Connect program is relatively a short-term program where we focus on the here and now. We don't go into details on the specifics of trauma. We want to help you right now. We're solution focused and interpersonal as well, client-centered. So first thing, let's have a safety plan and let's be stable. Let's make sure that the symptoms are regulated. This was done through practical mindfulness techniques, teaching her how to breathe properly, how to fight the automatic negative thoughts. But all of these were a little bit complex for that client who did not know anything about therapy. And this was the role of psychoeducation that took a lot of sessions, starting from scratch. Who am I? What do I do? What is this organization? And it was a very big moment for her, a moment of like an insight. Wow, am I allowed this service? Am I allowed to feel these feelings? And this is when empowerment and self-worth started to come in. So now you know what is therapy. Now you have techniques to control these symptoms. And now how are we going to use these techniques to make you feel back your self-worth and your empowerment, especially that her husband pretty much ruined her self-worth, body image. You could just like imagine what he did emotionally, specifically. And so we started to find, you know, those little things. She always loved makeup. She always loved looking after herself. And I used to give her those little assignments, you know what you're going to do today? You're just going to go buy yourself some makeup and do a full makeup, send that picture back home to your mom, and that's going to make you happy. Then we use the scale on how her mood is going to change from 1 to 10. And she used to follow that schedule because it used to make her feel better. Then came behavior activation, which is a very strong tool when you deal with depression, because the more you do, your behavior becomes activated and you feel that you want to do more. So I took it to the next level. Let's do a little bit. I think that is a little bit harder because one of the things also that she loved is the beach and coffee, but she does not speak a word of English. So we took a few sessions just practicing how to go and ask a barista for a cup of cappuccino. And we kept on doing that, role playing. She was shy. She would hide her face. I can't say that. What if he judged me? What if he did this or this or this? Until we were able to actually do that. And by the way, this is not a simple step for a woman with that very rich history and that intense level of experience. That was a very big moment when she came back into the session saying, "You cannot imagine what I did." We were celebrating as if we won the World Cup, and it was genuine and it was real, because I knew then that this was the beginning, that this woman knew that she could do things. So came the next step. Now let's put long-term goals. What are we going to do? English is the key. Let's learn English, but the social isolation isn't helpful. So I'm not ready to go to TAFE to take courses. So she started to actually apply for courses online to start learning English. And then we have goals that I'm going to integrate within the society. I'm going to make friends, and maybe I'm going to work. What about the status quo? This woman currently is learning English. She goes from time to time to take a cup of coffee. And guess what? She filed a divorce case and she's waiting for the hearing. So that phenomenal woman started from not knowing that she has the right to feel those feelings, and she had the right to actually feel heard and safe and valid, to an empowered woman who's currently filing for divorce by herself and believing that she has a second chance. So I believe that the prognosis, if Mehak would agree with me, is pretty good for that woman. And I'm really hopeful that she's going to keep that stamina going on. But all of this wouldn't have happened if it wasn't for the cultural element and the environment that STARS offer, which we take much pride in. And this is a part where Mehak's going to talk about right now.
Thank you, Noha. So thank you for sharing the story of this woman, Noha. That was really powerful. I suppose the two things that that I'm going to quickly touch on from that story are having some cultural competence in offering a service to clients at STARS, and the second will be working with interpreters. So in terms of cultural competence, I think this is a skill that needs developing as we keep working with clients. At STARS, we have because we have a diverse set of clients who come and access the service, we also have a diversity in the staff that work here, and we speak a number of languages between us. We also have, so what we do at STARS, and I know that lots of organizations have a component of cultural competence that they build into their organization, and everybody does this differently. I can tell you what we do. So one of the things that we do is every quarter we have an all-staff planning day. And at each of those planning days, we have about 2 hours of training on a different culture from the population that accesses our service. So the previous one that we had last month, was a staff member who spoke about the Chin people, and she also talked about the intricacies of the culture, people who come from Myanmar, and what the different what people's identities are who live there, the cultural component, what is important to them in terms of values, the languages they speak, and some of the barriers that a worker can face in accessing and service in bringing the service to people from that region, and how do we overcome those challenges. So it was a very practical training, and we do that on a very regular basis at STARS, so that the staff get a deeper understanding of the culture or the cultural background of some of the clients that access the service, so that we can provide a service that is safe. Safety is something that Noha spoke about in detail and quite repeatedly in her story, and that clients feel welcome here, no matter what cultural background they belong to. The other very important consideration is the use of interpreters when we support our clients. Now, this is actually a training on its own, but I'm hoping to give you a few highlights or a few key points of what we do when we work with interpreters. So at STARS, we have access to interpreters through various organizations like TIS or ABC. We have on-call interpreters, but we also have STARS pool interpreters. So we have a pool of interpreters that we have acquired over the years, and we ring them for support. These interpreters are from all different cultural backgrounds and languages. Some of the things that we keep in mind while we work with interpreters are that the more personal and emotional the information, the harder it is to communicate in a second language. And so we always, even if a person says, let's say a person comes into STARS as a client and says, I can speak okay English, I don't need an interpreter. We will value that. And we will respect that decision, but we will make it very clear to the client that having an interpreter is possible. And I will say something like, when a person is sharing personal information that is of an emotional nature, sometimes it is easier to have another person who speaks the language in the room who can translate it all back to me, so that I get a clearer understanding of what the client is trying to say. I do try and speak quite in detail about confidentiality when we speak about interpreters as well, so that I'm trying to give the client the choice, but it's also an informed choice in making a decision of whether to have that interpreter or not. We always use accredited interpreters, and we try and not use children or family members for sessions. Having said that, sometimes for preliminary appointments or for the preliminary conversations that happen with clients, if there is no access to anyone interpreter at that time, or it's difficult to establish that trust, we will use the help of children, but older children and family members, only to make initial contact and with consent of the client, and only to communicate the time for the appointment if the client allows it. We do offer double time for appointments when we are using an interpreter in the session, and we talk to the client, not the interpreter. So the conversation is between the client and the clinician or the worker, and the interpreter interprets it for each person. We don't tell the interpreter to say, hey, could you say to the client, please, that I'd like to book an appointment next week? No, that's not how we do it. We would speak to the client, and the interpreter would be translating that for us. And particularly after heavy sessions or quite intense sessions, we always try and offer the interpreters an opportunity to debrief with us. If not at the same time, then maybe at a different time, because interpreters are constantly running between appointments. And so If time permits, then on the same day. If not, then we will offer to book in a time just to debrief, so that we kind of offer support for them as well after that session. When we are booking interpreters, again, we offer as much choice as we can in terms of whether they want an interpreter from a particular ethnicity or from a regional person who speaks a particular dialect, or from a particular region or religion or gender, etc. And we always say we give the choice to have a face-to-face interpreter or a telephone interpreter. And an example of that is I have been supporting a client who is from a very small community in Adelaide. So they have come from overseas as a refugee, but belong to a small ethnic community within the larger community from their region. And within that small community, everybody tends to know everybody. And so this person refuses to have a face-to-face interpreter for our face-to-face appointments. So the way around it is I meet the person face-to-face, but we have a telephone interpreter from TIS who is from interstate. So that person doesn't live here, the interpreter. And when I'm in the session, I don't use the name of the client within the session to protect their confidentiality, to preserve their confidentiality and to protect their identity. So there are lots of nuances that we have to consider when we use interpreters. It's I will not be able to go into a lot of detail because of the time limit, but feel free to ask more questions in our Q&A session, which is coming up right about now. So that's it from Noha and us in terms of the presentation. I will try and minimize this.
Excellent.
And leave the floor open.
Just stop share. Yes, stop sharing, Meg.
Okay.
Great. Excellent. Thank you so much to you both. That was really interesting, and I love the use of the case study or, you know, personal stories, because I think it really brings things to life, and you know, particularly for us that work in drug and alcohol or sort of any of the community services, I suppose we identify with people's stories all the time, and so that sort of really brings it to life and gets us thinking about you know, dimensions that we might not have thought about before. So excellent. Thank you both. I'm not seeing any questions in the Q&A, but please, we're a small enough group that if you want to turn on your camera and your microphone, please feel free. Catherine, you've got your hand up there.
Hi, I just wanted to check, do you work with clients from all over Metro Adelaide, or do you have boundaries?
No, we work from clients from all over Metro. We have 2 offices. We have an office in the city and we have an office in Salisbury in the north. So we are able to also offer appointments outside the office in a community center or a place that is closer to their home, perhaps. But we do encourage them to come into the office, into any of these 2 offices. We also actually have an office down in Mount Gambier and Naracoorte, because there is a large refugee population that lives there. So we have a couple of workers who provide services there.
Excellent. Thank you. That answers my question, because I'm down at Seaford, way down south.
Oh, okay. But
and I just want to add something, Mehak, that also one of the things that we do, that sometimes with very special cases, we do home visits even.
Yeah.
Fantastic, because I work with, I'm from CAFS, so I actually work with a lot of mums with newborns. So getting into the city can be quite tricky.
Yeah.
Thank you.
Fair enough. No, we can always work something out for clients who can't come to the office. Our ultimate goal is to really give the agency to them to, you know, to be out and about and things. But of course, with newborns, you know, that can take some time, and we understand that. But we'll try and work as much as possible alongside the client to see what is best for them. So yeah.
Excellent. Thank you. Ramon has just put in the chat to say thank you both for your presentation as well. Do we have any more questions from the floor?
I can talk quickly about referrals as well, because I realized that I missed that bit.
Yeah, that would be great.
So I will bring up so the bit about referrals. It's very easy to make a referral. This is the slide about referrals. We have a phone number. We have one phone number for STARS that you can feel free to ring and speak to the intake coordinator for the process if you're unsure. But if you were to log into our website, there is a form. There is one referral form for all services that STARS offers. We are working to kind of make that form a bit more user friendly, because as I said earlier, STARS has grown in the last 2 years as an organization, and we now suddenly offer more programs than we used to. So they are currently listed on the referral form, and the Thrive and Connect program is called the Called Mental Health Program on the website. What we are going to do in the future is to put a little, maybe a descriptor or a one line about each of the programs, so that the person who is referring can have a bit more clarity around what they are trying to refer to. So feel free to download the form, fill it up, and then send it off to intake@stars.org.au or ring for questions. If you were wanting to make a referral to the Thrive and Connect program, Noha and I can leave our numbers and email addresses at the end of the presentation. You can feel free to reach out to us. We now have a project officer who can also take queries, and I can leave her number as well, and email, so that you can reach out for questions if you're not quite sure where to refer to, which program.
And clients also, Mehak, could refer themselves. So we have people who have heard about us, and if they are above 18, correct me, Mehak, if I'm wrong, they could just come and refer themselves.
Absolutely.
Fantastic. Excellent. Any other questions from the group? I was just wondering about, obviously we're from a drug and alcohol background, and obviously you would come across clients who are struggling with some of those issues. What do you think is different about, a migrant or a refugee community? How do alcohol and drug issues kind of differ for people from different cultural backgrounds or trauma backgrounds?
Do you want to answer that, Noha?
Yeah, I'm actually working with a client with us currently with a similar problem. So I think one of the things that is different that I have been seeing based on my experience is the lack of psych education. So many of them, they might indulge into certain behaviors without actually understanding the consequences. And other part would do this trying to fit in. So it's not something that they want to actually do, and sometimes they don't even enjoy, but it's a loop at the end, and they find themselves hooked into that because this is the way for them to bond. This is the way for them to make friends. So this is based on the people that I have worked with so far. If you have another thing to share, Mehak.
Yeah, I guess I've worked with several clients over the years who've presented with issues around drug and alcohol. I have to agree with Noha. Sometimes, it's about coming into a new culture and seeing that this is one way to make connections or relationships, and so they would get into it. And we see this in the more younger population, but also in the older population, or sort of not so much the young people. It's the lack of psychoeducation. Often it's about starting from the beginning around the fact that If this is something that is a problem for you, then there is support available. I think that concept is alien to them. And then it's about advocating. If they agree, then it's about advocating on their behalf to receive that support from the relevant resources or organizations. What I have also found is that there are a number of clients for whom this is a bigger issue, and advocating for clients such as these, has not been easy. And we like to call them the missing middle, or the people who fall through the cracks, essentially, because they are now struggling with drug and alcohol to the point where, even though we're referring them to services, they're choosing not to have that support. But as a result of that, and they're sort of falling through the cracks, not attending appointments, but continue to be vulnerable. It's something that we are sort of trying to get more training on, trying to find, more resources to support these sort of group of clients. But it can be quite challenging for some situations.
Yeah, I was just thinking as you were talking, having grown up in Australia, just how much alcohol is part of our sort of socializing and sort of part of our culture. We use alcohol to celebrate and commiserate and, just getting together on a Sunday afternoon. The alcohol is everywhere in particular. And yeah, I can see how that is kind of the way you make friends. You all head down to the pub or go to somewhere for drinks. So yeah, if you're not used to that, I can see how that would be very easy to sort of fall into.
One more thing, Sam, if I may add, is that also some of them, they use it as a medication because they're too sad or too depressed, and they just want to pass out.
Yeah, exactly. I mean, that's a very common reason, I think, for everyone. We find lots of clients coming into services who are experiencing mental health symptoms, and using one substance or another just makes them feel better. So it's hard to sort of overcome until you can sort of deal with some of these issues. So yeah. Did you mention that you provide training on how to work with interpreters? You said there was like further training.
We provide lots of training opportunities. If your organization, so we provide some regular training from within the organization. So the accidental counselor is one of them, and core concepts in refugee trauma is the other. But if you were looking for tailored training on topics such as working with interpreters or working with cultural competence, that is something we can make for the organization. Yeah.
Excellent. All right, we might have to chat further about that. And as always, for people attending, I'm always very interested in training needs. So if that's something that appeals to you or something that you see as a need in your organization, I'm always really happy to talk about that. Julie, you've got your hand up there.
Yeah, I was just going to ask what you do with clients that have got the drug and alcohol problem. Do you have somewhere you refer them at this point?
We don't have thanks for the question, Julie. We don't have one organization we will refer them to. We'll try and find an organization that they're willing to sort of work alongside. I guess it depends on what their goals are, because ours is a voluntary service. And I know that a lot of the services out there are voluntary as well. We have worked closely with DASA, but we also, yes, there are a few not-for-profit organizations that we work with closely, but it's very client-led. Because also, having said that, for some clients, if drug and alcohol is the main presenting problem, then it will make the trauma recovery hard. And so one of the goals would be to try and encourage clients in getting that support to manage that part of their concerns, so that they can come back for trauma recovery, back to STARS.
I was just going to say that I work for the Salvation Army, so it's the Sobering Up unit.
Yeah.
But we also have a counselling team here too, the WELL program. So I don't know if that's something that you would want to look into.
Right.
Yeah.
We'd love to. I mean, I didn't know about that. We'd love to know more.
Okay, well, maybe I'll get them to give you a call if you're interested.
Yeah, absolutely.
It's worth exploring whether it's any use to you or not, whether you'll determine that.
Absolutely.
Thank you.
All right. Thanks, Julie. Anyone with any last comments or questions before we let Mehak and Noah go after their fantastic presentation? Last chance? No? Excellent. Well, thank you so much for your time today. I found it very informative, and, you know, I've known about STARS for some time, but yeah, to get into some of the nitty-gritty of the services you provide was super useful for me, and I'm sure for others. So thank you so much for everyone. We've got 2 more seminars in the series, so watch out for our emails and sign up for those. We're also put out a recording of this. Once I chop off all our IT issues from the beginning of the recording, then I'll upload it for everyone to access later, or for you to share with colleagues who weren't able to make it today. So thanks everyone for your time, and we'll see you again soon.
Thank you, Sam, for the opportunity.
Thank you.
So much.
Thank you.
Thank you.